So I am delighted to introduce our next speaker, Tom Ortel. Dr. Ortel is a professor of medicine and pathology and the director of the Anticoagulation Management Service and director of the Clinical Coagulation and Platelet Immunology Laboratory at Duke University. His clinical and research interests include thrombotic and hemorrhagic disorders, antiphospholipid syndrome, heparin-induced thrombocytopenia, and anticoagulation management. This morning, Dr. Ortel will talk on portal vein thrombosis and heparin-induced thrombocytopenia, two difficult problems. Tom.
So I'd like to thank Andy, Maggie, and the organizers of this session and the foundation for inviting me to come here and speak to you. At risk of sounding like a broken record, I would like to introduce my talk by saying, okay, fortunately, most pregnancies do just fine, and hematologists never hear about them except if they're the father or the mother, fortunately. Everything that we've been talking about is extraordinarily rare, and so not only are my two topics rare, but they're so rare they gave me two to talk about. So we're going to cover a couple of issues that are uncommon, but they're very difficult to treat when they do occur. And here are my disclosures. And we'll start out with a case, and then a couple of questions about the case. And actually, in case you don't believe me, there is a case report out there of a patient with portal vein thrombosis and HIT developing during pregnancy. Now, this person that I'm going to describe, however, is a 26-year-old woman, first pregnancy, presented at 31 weeks gestation with abdominal discomfort and thrombocytopenia. She had a history of polycystic ovarian syndrome, but no prior history of VTE. She had prior smoking history, but she quit when she became pregnant. She is overweight. Belly is tender on examination. She was mildly thrombocytopenic, but everything else was normal. Electrolytes, renal function were normal. An ultrasound was obtained, and she had an acute occlusive portal vein thrombosis. So we'll start with a couple of questions on portal vein thrombosis. The first one is, which variable in this patient has been associated with an increased risk for portal vein thrombosis? Obesity, pregnancy, history of tobacco use, polycystic ovarian syndrome, or thrombocytopenia? Okay, kind of split out among the different topics. We'll go through that and cover that in detail. If I can go to the next question. So what's the appropriate management strategy now that you've diagnosed acute portal vein thrombosis in this patient? A, observation. B, antiplatelet therapy. C, anticoagulant therapy. D, inferior vena cava filter until after delivery, then convert to anticoagulation. Okay, so anticoagulant therapy and a couple of interventional radiologists are in the room placing those inferior vena cava filters. In any event, so let's talk about this. Again, as you've heard before, there's really no evidence. Everything is really case report stuff and basically expert opinion or what I would say that I might have done or I would have done. So first, what's the incidence of the problem overall? Okay, portal vein thrombosis is a very uncommon thrombotic complication. One of the best studies we have is actually quite dated, but it's probably the most objective information out there, which was a review of a computerized registry of all admissions to hospitals in a single country, Denmark, over a 5-year period. And there, the overall incidence of portal vein thrombosis was less than 4 per million individuals per year. It's important to recognize that since then there have been other studies that have come out, including autopsy studies and a number of other things, suggesting the incidence might be higher, and there is also some studies suggesting the incidence might be higher, partially because of the fact that we're scanning more people for a variety of reasons and then turning up these non-occlusive clots. This is data on occlusive symptomatic portal vein thrombosis. So, non-cirrhotic, non-malignant portal vein thrombosis, how do these people present? This was a study published in the GI literature a few years ago. 136 patients seen at a single institution, older than 15 years. Gender was equally distributed between men and women, about 43 years of age. At presentation, about half of those people had esophagogastric varices grade greater than or equal to 2, which means you have something like a finger sticking into the esophagus at the time of presentation. However, it was less than 20% of them presented with acute GI bleeding as their significant clinical manifestation. The acute manifestations of portal vein thrombosis for the patient who presents symptomatically includes abdominal pain most commonly. It frequently radiates to the back. They may have fever, and less frequently ascites. Ascites usually is clearly a more progressive state. Mesenteric venous obstruction is uncommon in the absence of extension of thrombus into the mesenteric vessels. And in many of these patients, actually, symptoms are frequently completely lacking, particularly those individuals who have partial portal vein obstruction. And again, this is this population of patients who are getting scanned for some other reason, and you've turned up a portal vein occlusion. So the diagnosis initially is made by ultrasound, and you can see that it will demonstrate an occluded portal vein with collaterals, and you can see this kind of coiled thing over here in the figure. I can't quite get over there, I'm sorry. That will be picked up on an ultrasound, but also what you can use is a CT scan, which will demonstrate thrombosis within the portal vein. And there you can see the dye is partially occluded by this clot sitting inside the portal vein. You can also get a good assessment of collateralization, and the extent of collateral formation with CT scan. Now, there's been a number of studies that have looked at what are the risk factors associated with development of portal vein thrombosis. And the problem is, if you look for enough stuff, you will turn up a lot of things. It's important to recognize that many of these patients had more than one cause. And on the next slide, I'll show you also the inherited risk factors that have been associated. Frequently, people have a combination of inherited and acquired. Most commonly are the pH-negative myeloproliferative disorders that you need to screen for, particularly essential thrombocytosis in young women. Antiphospholipid syndrome has been associated with it. PNH has been associated with portal vein thrombosis, although it's more frequently associated with Budd-Chiari syndrome. And then a variety of things, including oral contraceptives, pregnancy, and in the early postpartum setting. Patients with pancreatitis, diverticulitis, or other inflammatory conditions next to the portal vein may occlude it off. And then patients who've recently undergone major abdominal surgery. And as you can see on the side, depending on the study you pick, you can have anywhere from a couple of percent to half of the patients screened. If you look at inherited risk factors, again, if you screen all these people for things, you'll find stuff. 5-Leiden's been reported in a number of patients, prothrombin G2210A, as well as deficiency of protein C, protein S, and antithrombin. Elevated factor VIII levels, I would urge people to use caution on when you check those in these individuals, and that you definitely want to check them when they're not in an acute inflammatory state or obviously during pregnancy or other reasons. So what should you do? And what's the data that would suggest that you might want to do it? So this was a study that was published last year and recommended that anticoagulation should be started for acute portal vein thrombosis and considered in patients with extensive thrombosis if the clot has been relatively recently diagnosed. Now, obviously, this means that you've got symptoms developing in a patient, so you have some idea of the timing of when this occurred. And this was a study that was presented. Again, small numbers. So 33 patients total presented, of whom 31 were treated with anticoagulants. And then of those, about 90% or so had some kind of follow-up imaging. And the important thing that was recommended, that led to the recommendation that you should anticoagulate these folks, is that about a third of them ended up having complete recanalization of the portal vein with anticoagulant therapy. You don't really have a control arm, though, because the no anticoagulant therapy was only 2 individuals, and neither of them recanalized. You did get partial recanalization on about half of the patients. So anticoagulant therapy is started. Then the big question is, well, how long do you continue anticoagulant therapy? And there's been one study that addressed this that showed that recanalization seldom occurs after the first 6 months of treatment. So you get your best bang for your buck early in the clinical course. And that was based on this study that was published a couple years ago in Hepatology. The different lines represent different locations of the clot, whether it was splenic vein alone, whether it was portal with mesenteric. But what you can see is that for most of these patients, 6 months is here. You get the best improvement in revascularization, and then after 6 months, you don't have as much benefit. So for the purpose of reopening an occluded vein, the 6 months is the critical time frame. However, if you look at a lot of the guidelines, portal vein thrombosis is considered one of these unusual clots, and it's often recommended in these people that they continue on anticoagulant therapy, particularly those with whatever you might call thrombophilia, a personal or family history of thrombosis, and with intestinal ischemia. The other thing that's important to recognize is that these folks are at an increased risk for recurrent clot. So not only are you trying to treat them for their initial event, but if you continue therapy, it would be for the consideration of secondary prevention of new clots. So in this particular study, 26 of 119 patients sustained 38 subsequent thrombotic events, including 18 with DVT, 5 with PE, and then the rest with other intra-abdominal clots, sometimes also with associated infarctions. So the overall incidence rate of recurrent clot was 5.5. Now, obviously, this has to be counterbalanced against bleeding risk in the individual patient. And this particular study found that the global incidence of GI bleeding in patients with portal vein thrombosis was 12.5 per 100 patient years. So you do have a significant bleeding risk, and that needs to be balanced against the continuation of anticoagulant therapy in these folks. However, there was no association between anticoagulant therapy and the risk and severity of GI bleeding. So just because you don't have the patient on some kind of antithrombotic therapy doesn't mean that they won't bleed. This has led to my approach in these types of patients is that we will frequently also be regularly re-evaluating their varices just to see what might be their potential risk for bleeding if I continue them on anticoagulants. Now, what about fetal outcome? Because the median age, again, is relatively young, so you do have a fair number of women who would still be contemplating having children who might have portal vein thrombosis. This particular study, I think it's probably come out now since I put the slides together. 45 pregnancies in 24 women with known portal vein thrombosis. Median age at diagnosis of PVT was 26 years. Median age at conception was a few years after their diagnosis. And what you can see here are the fetal outcomes, which fortunately out of the 45 pregnancies, half had what was considered term delivery, greater than 36 weeks, preterm and early term, and then here you can see about a quarter of the patients did have miscarriage or fetal loss. So you can get these women through pregnancy with good fetal outcome. The maternal outcome, however, is also of importance to follow closely, and you can see here it's broken down, or they broke it down in this particular study into perinatal complications, liver-related complications, thrombotic events. Again, you can see you have to counterbalance if you're going to anticoagulate the patient during the course of the pregnancy. There is an increased risk of variceal bleeding. So this has to be considered as you take these people through pregnancy. However, the authors concluded pregnancy should not be contraindicated in stable PVT patients. They just didn't tell you what to really do with them. Let's put it that way. So question 1. Going back to visit the questions again on portal vein thrombosis. Which variable has been associated with an increased risk for portal vein thrombosis? Obesity, pregnancy, history of tobacco use, polycystic ovarian syndrome, and thrombocytopenia. Okay, that's correct. Pregnancy has been probably, if you look hard enough for all the others, you'll probably find them. But obesity has not been associated with it, nor has PCOS. The next question, Appropriate initial management strategy in a pregnant patient presenting with acute portal vein thrombosis, observation, antiplatelet therapy, anticoagulant therapy, or IVC filter until after delivery. Excellent. Anticoagulant therapy would be the choice unless you felt that the patient was at too high a risk for bleeding, in which case then you would withhold the anticoagulant therapy. But again, that would only be in the setting where you clearly feel that the patient's at high risk for bleeding. So this patient started on anticoagulants, initially started on enoxaparin. And of course, when you have one bad thing happen to somebody, usually something else bad is going to happen. Platelet count starts dropping, and by day 11, after starting at enoxaparin, it's down to 37,000. A heparin platelet factor 4 ELISA is positive. The C14 serotonin release assay is sent and is also positive. She has no clinical evidence suggestive of clot, no bruising or bleeding, so you stop the enoxaparin. So the first question, how frequently does HIT occur in women being treated with unfractionated heparin or low molecular weight heparin during pregnancy? 1 in 10, 1 in 100, 1 in 1,000, less than 1 in 1,000, or it's never been reported? Wow, okay. Obviously, it has been reported, or they wouldn't have asked me to talk about it, so that one can't be the right answer. And hopefully it's not 1 in 10, or Dr. James wouldn't have time to be out of delivering people with a HIT during pregnancy. The next question, which of the following agents are potentially, and I'd underline potentially, useful in a pregnant patient with acute HIT? Warfarin, fondaparinux, dabigatran, argatroban, rivaroxaban, or bivalirudin? Okay, the majority picked fondaparinux, followed by argatroban. Good. So, HIT, as everybody in here knows, thrombocytopenia with a platelet count less than 150 or a 50% drop from baseline, starting within a week to 2 weeks after starting heparin. You usually rule out other causes of thrombocytopenia, with or without thromboembolic events, and the positive laboratory test. So what is the incidence? What's the data? Okay, this study came out a few years ago looking at 244 pregnant women and 244 non-pregnant controls treated with unfractionated heparin at 3 hospitals in Utah. And here are the results. And the key thing is that there are obviously some significant differences in the groups, including the ages. How many were getting treated for VTE was comparable between the groups. A little bit more women were getting prophylaxed during pregnancy. But you can see here the key difference also is that the number of unfractionated heparin exposure days was substantially longer. A reasonable number of women developed thrombocytopenia, but thrombocytopenia is not that uncommon during pregnancy. However, none of these women had HIT. Another study that was published in British Journal of Obstetrics and Gynecology looked at enoxaparin, had 624 pregnancies in 600 women between 88 and 97. And what they found was that, again, a similar age, most of the women either with VTE treatment, but most by far and away was for prophylaxis. A longer course of time that they were exposed to low molecular weight heparin, depending on the length of time left in the pregnancy. And you can see here, though, that thrombocytopenia felt to be truly secondary to low molecular weight heparin occurred in 1 of those patients, or 1 in 1,000 people. Venous thrombotic events were more common, but not related to HIT or low molecular weight heparin-induced thrombocytopenia. So the diagnosis, this was a table that Dr. Gal Arapali and I put together a couple years ago, just trying to strategize on the best way to look at these patients. It's important to first stratify them according to clinical presentation using some kind of scoring system. If you have a low score, whether the woman's pregnant, whether she's not pregnant, if you have a low score, basically don't send the test because you probably don't want to know an answer in that particular situation, and continue them on what you have them on. If you have a higher intermediate score, then you would discontinue heparin and consider an alternative anticoagulant. The 4T score is what we most commonly use, which everybody in here has seen, which is the thrombocytopenia. You get a score of 2, 1, or 0, depending on how thrombocytopenic, what's the timing of the platelet count drop, whether or not they've had a thrombotic event, and whether or not they've had other causes of thrombocytopenia. And then you grade it based on the sum of the scores. Score 0 to 3 with low likelihood, score 6 to 8 with high likelihood. It's important to recognize, if I can go back, that you can actually have a clear other cause of thrombocytopenia and still have a 4T score of 6, which would be high likelihood. So just because you have other causes doesn't mean that you can completely rule it out. You still have to have it in the back of your mind. Once you've clinically suspected it, then we recommended using the enzyme immunoassay, which is most commonly used, and then you can decide if your patient clearly has HIT or less likely, and in which case you may want to get a serotonin release assay to try to confirm it. The assays are shown here. Most commonly used in the United States are the serologic assays, either the PF4 heparin polyspecific IgG A or M ELISA, or the PF4 heparin IgG ELISA. This gives you a little bit better specificity. However, you do lose a little bit of the sensitivity on the IgG specific assay. Serotonin release assay, I think, is done in maybe 3 labs in the United States, something like that, send out labs, but you can get it if you need it. So treatment of HIT in pregnancy, obviously you stop the heparin, you stop the low molecular weight heparin, you avoid warfarin in the acute setting, and then you start something, okay? So what is the data on the individual agents? Fondaparinux does have some evidence primarily in animal models, but there is minor placental passage has been reported, but anti-factor 10A levels are generally low and no adverse event reported during the course of the pregnancy. There are multiple case reports that have described the use of fondaparinux in pregnant patients with various contraindications to heparin and low molecular weight heparin, and in the reported cases, pregnancy outcomes have been successful. This was actually a nice review that was in Thrombosis Research earlier this year. What about argatroban? Okay, argatroban, actually, there are 3 case reports out there, all in patients with clinical suspicion for HIT. 2 received argatroban briefly and or were treated with fondaparinux during the pregnancy. All 3 pregnancies resulted in successful outcomes. What about the other agents? Well, warfarin in general should be avoided in acute HIT, whether the patient's pregnant or not. During a pregnancy, if you're in the 2nd and 3rd trimester, you could use warfarin for part of the pregnancy course. Although if you have other options, I would try to use that. Bivalirudin has no published data. Those of us who are older in the room remember using dinaparoid, which is what many of us actually used for quite some time. There's a couple case reports of using lepirudin during pregnancy. Neither of those agents are currently available in the U.S., and there's no experience with dabigatran or rivaroxaban. So, revisiting the 2 questions, how frequently does HIT occur in women being treated with unfractionated heparin during pregnancy? 1 in 10, 1 in 100, 1 in 1,000, or less than 1 in 1,000, or never? Okay, so evenly split almost between 1 in 1,000 and less than 1 in 1,000. I'd pick the less than 1 in 1,000 overall. I think it's very rare. The one case that was reported in the low molecular weight heparin study, I'd be cautious saying that that was truly HIT. So fortunately, this is a very uncommon complication. And the next slide. Which of the following agents are potentially useful in a pregnant patient with acute HIT? It says you can pick two. Warfarin, fondaparinux, dabigatran, argatroban, rivaroxaban, or bivalirudin. Okay, the only two for which there are any data, keeping in mind that the fondaparinux is a small number of case reports, and there's 3 for argatroban, and the others just don't have anything. So fondaparinux and argatroban are really the only two that you've got any data on. Unfortunately, we don't have any other agents to use. So with that, I will end. Thank you very much for your attention. I'd be happy to entertain any questions.
Actually, I have 2 questions. First is, do you know whether argatroban crosses the placental barrier? And the second question is, do you test your pregnant women with low molecular heparin on platelet counts?
Okay, so the first question is about the argatroban crossing the placental barrier. And that's a very good question. I'd be concerned about it because it is a small molecule, that it would cross and that you would get some anticoagulant effect. That's why I was actually amazed that I found people who tried it. I'd be very hesitant to try it. And once Dr. James comes back, or Dr. Branch, if they've ever had experience in using any of these, I'd be interested in their efforts, or as far as their outcomes on using those, because I would have been very hesitant to use argatroban, although it's been used. The second question was for the woman who is being treated with enoxaparin during the pregnancy. How often do I monitor platelet counts? Is that specifically, or how often is it? There is no recommendation on how often you should do it. I think that it's reasonable to check it a few times during those first 2 weeks, but then once you get past 14 days, there's no incidence or no evidence that there's increased incidence for HIT developing longer. So then I probably wouldn't do it any more than what I would do for the normal monitoring of a high-risk pregnancy. Let's put it that way. In the back.
Thank you for the interesting talk. With respect to the portal vein thrombosis, you mentioned the papers you showed were symptomatic women that had complete occlusion, yet you commented that this is often picked up on screening for some other reason. So do you treat those people that you incidentally find something, or is that giving them an illness that they were really never going to suffer from?
Okay, so the question isn't necessarily specific to pregnancy, but it's a whole issue of treating the serendipitously identified portal vein thrombosis in general. The current guidelines actually recommend against treating serendipitously identified intra-abdominal clot, and I tend to lean that way. I think it also depends on the quality of the imaging study. If you have something that looks like it's non-occlusive and it's in a cancer patient and the patient's asymptomatic from this thing otherwise, I might be more likely to just follow it. I've actually had a couple of patients where I went and talked with radiology about it, and they actually recommended a more dedicated imaging study on the vasculature, and on that study, it was gone. Now, if you have somebody with a serendipitously identified occlusive clot, I think it's a little bit different. It may depend on the extent of collateralization that the patient has. It may depend on a number of other things. So I have no standard way that I do these. I will carefully look them over, however, and make sure that I really think I have a goal for what I'm going to do with anticoagulant therapy in that particular patient. Because obviously in those kinds of patients, I'm probably not going to get rid of whatever's there. It's probably there. And then the question comes down to, do I think that there's a value in the secondary thromboprophylaxis in that particular person?
Thank you.
Okay. Go ahead.
Not pregnancy specific, but when you treat with fondaparinux in HIT without thrombosis, do you recommend therapeutic dosing or prophylactic dosing? I've seen both.
And you'll probably continue to see both, and you can probably find in the literature evidence that both seem to work. Just to preface what I'm going to say. My general bias in this kind of a setting, in the patient with HIT with thrombocytopenia only and no thrombosis, If that patient has other in-hospital risk factors, I will probably treat them with prophylactic dose. It usually will depend on the individual patient, what I think their other comorbid conditions are, and how at risk they are for thrombosis versus bleeding that I'll treat them. I don't feel that the patient needs to have therapeutic fondaparinux for some extended length of time, but if you wanted to do that, I'd probably only cover them, at least initially, during the time they're thrombocytopenic and maybe for a couple weeks.
Okay. Hi, Tom. Given the half-life of fondaparinux, how would you manage this woman around delivery?
Well, before Dr. James moved to UVA, I just sent them over to her. Now, and that's an important question because of the fact that what we normally do with the low molecular weight heparins, in the absence of HIT, is we would convert that woman over to unfractionated heparin for that, let's say, 4 weeks before their planned delivery. Now, for this kind of a situation in which you have HIT kind of playing on there, I mean, the only option that you really have is fondaparinux, or completely controlling and deciding that you're going to go for a C-section and you bring them in, and I mean, you stop it beforehand and you go ahead and perform it. Now, obviously, the closer their thrombotic complication is to when they're delivering is also going to play into all of this. Fortunately, I've not had to make that call and haven't had to put anybody on our Gatroban. I'd be interested. Like I said, we've got a couple of obstetricians here. Andy or Ware, how would you cover that person in that setting immediately prepartum? Just hold the anticoagulant altogether. Again, based on lots of data, that's what we would do. But I think you unfortunately just don't have any other good options. So Dr. Branch's comment, for those who didn't hear that, is the half-life is long enough. You're going to have to also work closely not just with obstetrics, but also with regional anesthesiology, just because of the whole issue of epidural placement and things like that. So that's going to require clearly having a team approach before that woman gets to the point where she's going to deliver to decide what's going to be the best way. Well, thank you very much for your attention.